This video tutorial is to assist you as you make decisions about monitoring hormone therapy and ask the question, how do we know what type of test to use in different BHRT situations? So the objective is essentially just to go through this chart where we're looking at different tests: serum, saliva, 24-hour urine, and then Precision Analytical's unique testing format, and looking at situations where there's no supplementation, and then these various supplementation scenarios which require independent consideration in terms of which test might be best. So let's look first at situations where we have no supplementation at all. Serum, saliva, 24-hour urine are going to all create viable options in this situation. I think some have distinct advantages. When you're talking about sex hormones, probably the most challenging is saliva testing, just because the analytical methods really are difficult in terms of the very low concentrations of, in particular, estradiol and testosterone. When you look at one lab versus another, there's going to be some pretty wild fluctuations, and so that's a drawback to saliva testing. Probably its biggest advantage for sex hormones is looking at progesterone and estradiol throughout the menstrual cycle, which really isn't practical by other testing methods. So you can look at this patient, for example, has low levels of progesterone until ovulation at around day 14, and then up come progesterone levels, and then back down at the end of the menstrual cycle. And this can be a valuable tool when you're looking at single point measurements and you really want accurate values. I think other testing might be more appropriate. Serum testing's biggest advantage is probably that it's the most accepted just in terms of its prevalence. The methods are FDA approved. They're very easy to do. You're likely going to get very similar results and reference ranges from one lab to another, which is probably not the case with saliva, and probably not with urine testing either, since those methods are not standardized. Those are developed by laboratories in-house. And probably the biggest drawback to serum testing is that it's just not as comprehensive. You don't get metabolites of estrogen and androgens to help steer your clinical decisions. With a 24-hour urine sample, you're going to get that information. You're going to have mass spectrometry values, which are probably more accurate than what you would get with an immunoassay in a serum or saliva sample. You are going to get those estrogen and androgen metabolites, which again can help. Probably the biggest drawback to the 24-hour urine is just the difficulty of collection, and that's something that we've tried to address in our methods with our easy collection, is just to make it easier for the patient, but we still maintain accurate values with the most accurate methods of GC tandem mass spectrometry for the sex hormone metabolites, and that's going to be, I think, a big advantage as you're looking at sex hormones. When you move on to the adrenal hormones, then really your gold standard has been historically saliva testing, because you get the diurnal-free cortisol pattern, and that's a big advantage. But you also want to see the cortisol metabolites, and so there's a little bit of a drawback to saliva testing, and that's really one of the big drivers of motivating the testing that we developed, is to include both the diurnal cortisol and the metabolites, and that's going to make a much more comprehensive test. When you're looking at 24-hour urine, you're not getting the diurnal cortisol pattern as well. Labs are often measuring total cortisol and not free cortisol, so it's not a great option for adrenals. Serum also not a great option for adrenal testing, as you just can't look at that diurnal free cortisol pattern. So ultimately, I think the precision analytical method is really ideal for looking at these hormones without supplementation. So when we move on to supplementation, we want to break it down into the different routes of administration, looking at oral, sublingual, vaginal, injections, transdermal, and each one of these is unique, so we need to look at these separately. So let's start with oral, and with oral, progesterone really behaves differently than the other hormones, so we need to separate that one out. And what we'll show is that with oral progesterone and saliva, really the values are just not accurate with immunoassays, and that's really important. And also the kinetics are just too fast, and what we mean by that is this, that the values go up and down very quickly. So let's look at the data. Oral progesterone doesn't actually increase progesterone levels all that much. So if you look at this example here, the patient's got a baseline value, they take 100 milligrams, which is a typical dose of oral progesterone, and the values peak at 2 hours at less than 2 nanograms per milliliter. So we know that premenopausal levels are up above 4 or 5 nanograms per milliliter, even as high as 15 to 20 nanograms per milliliter, and the levels just don't get there with oral progesterone. If you contrast that with vaginal hormones, you can see that the vaginal hormones, really do get quite a bit higher. Because the progesterone, when you take it orally, is just so extensively metabolized in the first pass, you just don't get a lot of progesterone, and so the serum and the saliva values are really returning to baseline too fast to really get a significant measurement, and most of the tests are inaccurately high. And let's take a look at that. So when you take oral progesterone, the LCMS values show you what progesterone is doing. As we just showed, it peaks at 1 to 2 hours and then comes back down very quickly, never really rising to premenopausal levels. But when you measure serum levels with an immunoassay, you get values that are significantly higher. So these are measuring the same samples, but with different methods. And the most common methods are these immunoassays. And the difference between these two is simply that you have oral progesterone, so the body's going to make a lot of progesterone-like metabolites from that, and since those look an awful lot like progesterone, they will cross-react with an immunoassay and create a false positive. So these values are really not meaningful values, and that's going to be an issue for saliva and serum testing. When you look at urine testing, even when you take a small dose, now remember we just showed you don't really raise the serum levels much, but what you measure in urine, which are progesterone metabolites, get very, very high even with small doses because, again, the first pass metabolism is so extensive and you're measuring metabolites of progesterone in urine, not progesterone itself. And these metabolites can have some valuable information in terms of seeing, how much of the allopregnanolone potentially is made and how well that's going to work for a patient in terms of helping with sleep effects, but really there's really only marginally valuable information from urine testing. So with oral progesterone, testing is really of limited value. So when we move on to other oral hormones, they're going to behave a little bit differently. Serum testing works well for DHEA and estrogens, but again, you're not getting those metabolites, which is an advantage for urine testing. In urine testing, you've got some difficulties just because of the difficulty of avoiding first pass metabolism, and we'll talk about that briefly. With saliva testing, it can work fine with oral. You're really back to kind of the same situation as when there are no hormones, as you just have the difficulty of the analysis being difficult, and the fact that you're not getting any of the metabolite information. But it's a reasonable option for oral estrogen and DHEA. With a 24-hour urine, again, the first pass metabolism is somewhat difficult to avoid. So here's a situation of oral DHEA. So what we're doing in this situation is we look at, here you can see in the dark black the baseline values, and then they put these people on dexamethasone, which is meant to suppress their DHEA values. So you've got baseline, and then you've got induced deficiency. So this is just sort of an academic exercise for us. And then when we give back both the dexamethasone plus DHEA, which is essentially hormone replacement therapy, you can see that in this case we're monitoring testosterone values. They come back up. And what we want to show is that they create nice, flat levels to measure, and so it creates a situation where a serum measurement of testosterone in this situation is relatively easy to do and works just fine. When you're looking at oral estrogen, same situation. Remember we showed with progesterone the values go up and down really fast. With estrogen, they don't because of some of the recirculation that you get. So here's a patient's baseline, and then 3 weeks later, after they've been on the supplement, when they take it again throughout the day, their levels go up and down very gently, so making for an easier testing method for both serum and saliva. Now, when we look at urine testing, as we said, first pass metabolism creates some issues. So what we want to do in that situation is have the patient skip the supplement on the day of testing. And here you can see one individual testing at 2 different times on a dose of oral estradiol. And the difference is on the left, they are taking the oral estradiol the day of testing, and on the right, they've skipped it the day of testing. So what you can see on the left is these values, these are not meaningful values because these do not reflect what's going on systemically. What they by and large reflect are hormones that have been swallowed, gone into the gut, and been metabolized, so conjugated, and spit into the urine without ever having been in systemic circulation. So this estrone value of 210 is almost 10 times the reference range, but this individual doesn't have 10 times the normal levels of estrogen. It's simply an artifact of first-pass metabolism, and these values cease to be meaningful. So when you skip the day of testing, again, the estrogen levels are going to stay high for an extended period of time, so you can still take a look and see what the levels are, but more importantly, you can look at the metabolism picture. So we want to look at these 3 phase 1 pathways, because the pathway here to 2-hydroxyestrone is creating the so-called good estrogen metabolites. Those are protective, anti-estrogenic, anti-carcinogenic. And the 4-hydroxyestrone metabolites are carcinogenic, and the 16-hydroxy E1 metabolite is a very potent estrogen. So what we want to look at is compare what normal metabolism looks like to what this patient's metabolism is. You can see in this particular case, you usually make about 71% of the good estrogen metabolite, and she's making 87%. So this is a person who is really sending a lot of that estrogen down that favorable pathway and smaller amounts down the more dangerous 4-hydroxy and 16-hydroxy pathway. And don't pay too much attention to the estriol value. This patient accidentally forgot to stop taking their estriol cream, so that's a bit of an anomaly and doesn't really have anything to do with the subject here. But the point being, if you stop taking the estrogen or the oral hormones the day of the test, then you can get some good information about what's going on with that particular patient. But that's a little bit more difficult to do. But the main reason that this is advantageous is you can see that these bad estrogen metabolites, particularly the 4-hydroxy-E1, that creates DNA adducts. And when they measure those 4-hydroxyestrogen DNA adducts and look at how much patients make those, you can see that women at high risk for breast cancer and with breast cancer make a lot more of those DNA adducts than do the otherwise healthy control. So this is a really important consideration, and that's a major advantage of urine testing, is being able to see not just estrogen levels, but what is the body doing with that estrogen. Okay, let's move on to sublingual hormones. This is a situation where there really aren't any good options for monitoring in terms of changing a patient's dose based on a lab level. And why is that? Starting with serum testing, it's just too fast. So before you really can measure it, it's gone. So you can see here that we have patients taking a small dose, a medium dose, and a larger dose of testosterone. Now, while there's a difference between the 3 groups, by the time you get out here to 2 or 3 hours, there's really no difference between the 3 doses. So if we look again, remember this case where we took DHEA and then we monitored the testosterone. If you monitored it 20 hours or at 12 hours, you're getting about the same value. If you overlay a sublingual situation here, you can see that your only options are to measure out in here where the hormone is already gone, or you can monitor in this time period where you have an extremely volatile value that can double and triple in just a few minutes, really just the time of the blood draw. You can have those values changing dramatically. So there's really not a time where you can get a meaningful value. It's more likely to be misleading than it is to be clinically additive. So you're going to be really careful with serum measurements following sublingual hormones. For saliva testing with sublinguals, it's even worse because the hormones are in milligrams when you're taking a supplement typically. In saliva, what comes out of your saliva is in picograms. There are 1 billion picograms in a milligram. So the mouth gets contaminated, and the contamination of the mouth lasts longer than the increased systemic levels of hormones from the sublingual hormone. So for me personally, when I take sublingual testosterone, my baseline levels in saliva are less than 100. Yet when I'm at a peak level from taking a troche, I'm at 100 million. Now that value is going to come down very quickly. 20 minutes later, 30 minutes later, it's going to be significantly less, but it's still going to be a huge concentration relative to what's actually going on systemically with my hormones. So the results really are of no value, and some people have pushed the notion that if you wait 30 hours, then you get a viable number. If you wait 30 hours, yes, the contamination may be gone, but the increased hormone levels from the supplement are gone even sooner, so that really the values are not meaningful values. So with urine testing with sublingual hormones, the hormones get into circulation, increases your levels, and then from those hormones, urine is going to get its fair share of hormones. So that should work if you monitor that. But the reason it really doesn't in most cases is that doesn't work if you swallow it. So if you swallow the hormones, you get first pass metabolism. You're going to get essentially a false elevation of what's going on, and you really never know how much of the hormone your patient is swallowing. So there really isn't a solution with sublingual hormones that really helps with dosing. Now with urine testing, you have some added value in that you can look at some of the metabolism pictures and patterns, and that can be helpful. But in terms of really changing a dose, there really isn't a lab test that's all that helpful for that. So vaginal hormones, let's talk about mucosal membrane hormones. So this would be vaginal for a female. For males, sometimes we'll take it on the rectal mucosa, and that works as well. If we look at serum testing, a lot of people do this with serum testing. The problem with that really is that the rise and fall of the hormone is really unpredictable, and so when to test becomes pretty tricky. So when you take vaginal hormones, here's what happens. So this is vaginal testosterone for two different people. So we can see two different times when they're not taking the hormone, and then the other two situations where they are. But what you'll notice is, let's just say, for example, you test at 8 hours. At 8 hours, person number 1 has reached their maximum value. So that's the highest that they ever are in this study, whereas if you test person number 2 at 8 hours, they're back to baseline. So when do you test? You really don't know. And this is with two people taking the same exact supplement in a controlled study. So if we change the hormone to progesterone, so here's another study where they looked at progesterone, and here you've still got fairly elevated values at 24 hours. So knowing when to test gets really difficult because you've got a number of variables. You've got different hormones, you've got differences in the delivery. You can use, let's say, a small amount of a highly concentrated formulation, or you could use a larger amount of a lower concentration and give the same amount of hormone, but then the kinetics of the rise and fall of hormone is going to be different. It's also going to be different depending on the base, and so you've got a lot of timing issues, and you just don't know that information, along with, as we saw in that case we just showed, differences in the same situation from one person to another. So it really creates some challenges. So if we use instead urine testing, then we really have a better option because we're going to be collecting over a much longer period of time. So it reduces the timing problem. However, testosterone and estrogens, of course, are going to contaminate the urine. You're putting large amounts of the hormone in a region where the urine is coming from. So obviously you can contaminate it with those hormones. But for that, we've come up with a solution. Testosterone or estrogens must be conjugated to be excreted in urine. So if this represents testosterone, then before it can go into urine, it's got to be more water soluble. So your body adds either a glucuronide, which is essentially a sugar molecule, or a sulfate onto the molecule, and then it can be excreted into urine. So if this represents urine, you have down here all these testosterone conjugates, and when you take hormones vaginally, you're going to get a contamination from all this free hormone that's not actually getting into systemic circulation. It's a local direct contamination. So what we do in our method is we remove the free hormones first, leaving only these conjugated testosterones, and then those conjugate groups can be broken off and the testosterone can be tested free of the contamination. So normally a 24-hour urine is not a good option. Serum and saliva are of marginal value because of these timing issues. You really don't know when to test. And with our method, it really is an ideal option to represent a lot of time, but to get rid of the contamination issue. So lastly, let's look at a couple examples where the testing is relatively easy and one where it's very difficult. So pellets and injections. In these situations, you're really giving hormones in a slow, sustained release type of a situation. And so in those situations, really the testing results or philosophy that you use when you're not taking any hormone at all should apply here. So with serum, again, well accepted methods, you're not getting metabolites. With saliva, you've got difficult analysis analytically, you've got no metabolites, but both viable options. I think a 24-hour urine's probably a good way to go, and again, our method being sort of equivalent to a 24-hour urine and where you're getting the metabolites as well is a really good option. Now, when you look at transdermal hormones, so transdermal creams or transdermal gels, this is where it gets really tricky and really difficult, and I don't personally believe with a transdermal cream that any of the tests are really giving you additive value in terms of, as we said with sublingual hormones, and in terms of actually adjusting doses. So for serum, for urine testing, you're really getting, I think, an underrepresentation of what's going on in some tissue. And how do we know that? Because the saliva gland comes from a particular tissue and it gets flooded with hormones, with topical hormones, whereas the serum and the urine do not. So then a lot of people want to use saliva testing for transdermal creams. The problem with that is the values are just too variable and they change dramatically with different application sites, and there's some other issues. So let's go through that just quickly. Salivary testing with topical hormones. Saliva teaches us that some tissue, again, get more hormone than is reflected in urine or serum testing. And this is a very profound truth. But in terms of using saliva testing for a monitoring tool, that's where it really falls apart because they're just too variable. The levels change dramatically with, among other things, different application sites, different bases, and I think if you really look at the data, it's questionable as to whether that reflects systemic exposure. So let's look at a couple of these. We've got a man taking transdermal testosterone, and we can see here his peak values when he's putting it in different locations. So what you can see is up here by the collarbone, he's got a value of almost 100,000, whereas as you go further away from the saliva gland, then the values get much lower. So that really creates difficulty in terms of using this as a monitoring tool when you can change the results exponentially by simply changing where the hormone is applied. And so it really also gives us a kind of a different view of how that hormone actually gets into the saliva gland. And that's a long, I think, complicated conversation and a very interesting one, but it really just tells us we've got a much more complicated model here than just this idea that saliva represents free hormones or tissue hormones. We've really got more going on than just that. And as a monitoring tool, you really can't have this level of variation when you simply alter one variable such as application site. But if we look at another study where we held the application site constant, so in this case, this is single individual taking the same amount of hormone in different bases and putting it in the same place, and you can see wildly variable numbers. But the most problematic point with this data is if you look at the green results here, you get an increase for sure, but it's very gentle. And obviously when you look at these blue numbers, these are huge and wildly variable. So there's a very significant difference there. But what you'll notice is most people test about 24 hours after their last dose. And what do you notice is that those two situations result in the same value at 24 hours, yet they tell a very different story prior to that. And if you tried to test in this region here, you're going to get a wildly variable number. So there's really nowhere to test those where you're getting a consistent value that really has meaning. In this situation, we're holding all of these variables constant, so we're putting the same dose of the same hormone, progesterone, in the same base on women in the same location in a controlled study. And what you can see from this is you really get wildly variable results from one woman to another, and what you'll notice here is baseline values, like premenopausal values of progesterone, are way down here by this yellow line, like about 75 to 200, something like that. And you can see that every single woman in this study had levels that rose to at least about 10 times a premenopausal value. So everyone's getting an increase in progesterone from taking topical progesterone, but is the degree of that elevation, as variable as it is the degree of that elevation actually significant relative to the clinical picture? And I'm not sure it is. If we look at the clinical data with testosterone, for example, you can see some interesting things, because we have with testosterone a built-in mechanism, and that is, if we take too much testosterone, we're going to get LH that's going to go down in men. That's why their testicles can shrink. And if we give large injections of testosterone, that's indeed what happens, is that the LH will get suppressed entirely. So if we look at a situation where we're taking 50 milligrams of a transdermal gel of testosterone, saliva values go up over 15-fold. Not 15%, but 15-fold. A huge astronomical increase in saliva, which tells you there's a lot of hormone in the saliva gland. But the serum and the urine values only go up modestly. So what happens to LH in that situation? So these are hypogonadal men. So this baseline LH represents an elevation in LH. And if we give them large injections of testosterone, they would go clear down to 0. But with 50 milligrams of topical testosterone, they drop right into the reference range. So the LH suppression implies a modest dose, agreeing more with the serum and the urine testing. And also in these situations, if you look at muscle mass increase, you really only see the muscle mass increase if the serum is going up. And so we really have conflicting information when we look at serum and urine relative to saliva, and I don't think, looking at the data, that really any of those adds value such that you can track a dose and adjust a dose until you hit some sort of target, because if you do that with urine and serum testing, you're probably going to be using a lot more hormone than is required to alleviate symptoms. And yet if you use saliva, you really don't have values that are stable and are tracking with all of the clinical data. So there really isn't an option in there, where we really want to tweak the dose until we get a particular range. We really want to be careful with that. So if we pull the topical hormones out and just look at the spread of data and information here, and we ask ourselves, what's the best way to test? That's really why we built this precision analytical test the way that we did, is because we made it in such a way that we would have optimal value for no supplementation and optimal value with hormone replacement therapy. So with multiple spot urine samples, we get easier collection. We're representing a good part of the day, about 14 hours of the day, so we're not going to be as prone to these small fluctuations over short periods of time. We're getting more clinical information than you would get with serum or saliva testing by adding the metabolites into the picture, and we're improving the adrenal profile by looking at free diurnal cortisol plus the metabolism picture. We're getting good correlation with 24-hour urine collections, and the dried samples that we're using to do this, dried urine samples, correlate extremely well with liquid urine. So the patients really just have to take these urine collection devices and apply urine to the bottom portion and then use the label handle to hang them up to dry for 24 hours and then send those into the lab. So they're doing that 4 times. First thing in the morning, and then 2 hours later, and dinner time and at bedtime. And with those 4 collections, we can test the diurnal cortisol. And when you look at the diurnal pattern of urinary-free cortisol, it really parallels well what's going on with saliva. In this study, they looked at chronic fatigue patients and showed that the chronic fatigue patients show a similar diurnal pattern, yet lower than the healthy controls. And when they did that with spot urine samples like we're using, they get almost superimposable patterns of both the healthy controls and the chronic fatigue patients. So it really opens up the door for this testing to become a more comprehensive panel. And why this is really advantageous for adrenals over saliva testing is because, again, we're able to look at the metabolites. So if you look at these two situations, you've got the daily free cortisol pattern here at the bottom. The patient on the left shows low free cortisol. The patient on the right shows low free cortisol. And so when you look at the overall cortisol for the day, this is essentially the aggregate of those 4 samples, they're both low. So you can see the reference range is 11 to 31, and then the values here are below the reference range for free cortisol. So then your assumption is, okay, the adrenal glands here are not making much cortisol. But when you look at the total cortisol metabolites, so you can see most of the cortisol ends up in urine as a metabolite, and you can see in the case on the left, this person actually has elevated cortisol metabolites, meaning they are producing a lot of cortisol, yet they're still deficient in free cortisol, but extremely different in terms of what's going on with this patient as compared to the patient on the right, where their cortisol production is indeed compromised and is low. And so we want to treat these patients differently, but they look identical in saliva. So with the urine test, this is uniquely created to be able to differentiate between people who have these different issues with HPA axis function as well as supplementation issues. So we really feel like this is a strong option for the most relevant situations in testing sex and adrenal hormones. If you'd like more information on this test, feel free to reach out to us at info@precisionhormones.com or visit our website at precisionhormones.com.